Hello, and welcome to the Clinical Liver Disease video series. CLD is an official digital learning publication of the AASLD. I'm Sarah Repking, nurse practitioner with Rush University Medical Center and an associate editor with CLD. I'm here with Dr. Bob Fontana, professor of internal medicine and director of transplant hepatology fellowship at the University of Michigan in Ann Arbor. Go Blue. And he's also the author of Granulomatous hepatitis. Is it bugs, drugs, or other untoward culprits? Dr. Fontana, thank you so much for joining us today.
Well, thanks for having me.
So a couple questions about this really great article. How common is DILI encountered? For those who don't know, DILI is drug-induced liver injury. How often is it encountered with protein kinase inhibitors and other types of targeted therapies for cancer?
Yeah, so as you know, there's been just like a revolution in oncology care. So many more patients are receiving this class of drugs called protein kinase inhibitors. And amongst them, there's like 15 of them, but it is drug specific, but low-level transaminase elevations that aren't severe or progressive are very common, like 40 to 50% with some of these drugs. But like clinically significant liver injury, like this case in our article, is much rarer, certainly less than 1%. It's hard to say exactly, 0.1%, but it was a very interesting case, which is why I was sort of compelled to write it up and share it with the community.
And so I know you said about 40 to 50% with mild. With this, small percentage, do you see that the DILI tends to be mild or more severe in these, these cases, these more rare cases?
Yeah, so the rare cases are the severe ones that require more of a medical evaluation by like a GI liver specialist, like this case. This particular patient had a marked elevation in her ALK phos to over 1,500 and an elevation in bilirubin. So that's very different than sort of trivial transaminases of 50 to 60 that go away with continued dosing. So that's one of the reasons why I thought this was a good case to present to the community, to know when should you do a full workup, when should you do a liver biopsy, and then once you do all that, what do you do with the information?
And what do you think the value is of the liver biopsy in someone with suspected DILI? Do you tend to do those often, or do you go by the rest of the workup clinically?
Yeah, it's a great question. So we don't tend to do them in patients with very mild liver injury, meaning like an ALT of 5 to 6 times, no bilirubin elevation, because the liver will usually recover when you stop the drug, and there's really no clinical reason. It won't change what you do. So, any invasive test, you should think about, is this going to change what I do? This case, we did do a liver biopsy because we did this big medical evaluation and an MRI and, all these diagnostic serologies, and everything came back negative. And the patient still had a very high ALK phos and bilirubin. And that's part of what we wrote in the AASLD guideline, was that it should be for patients who don't improve or you're just not sure. And in this case, actually, it was both. She wasn't improving, and because she had cancer and was getting chemotherapy, the differential diagnosis is a little broader there, of like opportunistic infection, malignancy that's spread throughout the liver. So I think it brings up the point of what you do in a DILI case is dependent upon the clinical context with the patient right in front of you.
And, maybe not specific for this case, but typically what features on a liver biopsy would indicate a favorable prognosis, or where you feel comfortable saying, they're going to make a recovery, we think? Yeah,
right. So once you've sort of properly selected the patients that you're going to get, you can justify the risk of the biopsy, then how's it going to help you, right? Like I said, don't do a test if it's not going to change what you do. So we've learned from having studied this in over 3,000 patients in the Dillon network, that if you have eosinophils or granulomas on the biopsy, that bespeaks a much more favorable prognosis than, for example, severe necrosis or a lot of fibrosis. And this case is a perfect example of that. She had a lot of granulomas. It's nicely shown in the figures. And she responded very quickly to steroids, which we don't recommend for the majority of patients, again, if they're improving. But again, because she wasn't improving, and her oncologist was somewhat pushing me to say, look, this lady has gotten 4 years of tumor remission from these drugs. I've extended her life by 4 years. Tell me what I can do next. Is this DILI? Is it malignancy? So he needed to know, and I obviously wanted to help him with that. And so that's why we proceeded with the biopsy, and we're fairly aggressive with treating her, and successfully with a very short course of steroids.
That's great. Dr. Fontana, that was great. I really encourage anyone to read this article. I know a lot of us deal with patients with DILI in the hospital and kind of go head to head with oncology, and it can be really tricky sometimes. So
Yeah.
for those who haven't read it, I really encourage you to read it. Thank you again for joining us for another installment in the Clinical Liver Disease video series. And thank you to all those watching. On behalf of all of us on the CLD team, I hope you found this interview helpful. For more information about granulomatous hepatitis and its culprits, please visit us at www.cldlearning.com. Thanks again for watching.
Thank you. Bye-bye.